All right, we're on. Hi, I'm Anne, and today I'm joined by an expert in the field of airway health and sleep disorder breathing. Dr. David McIntosh is a pediatric ear, nose, throat doctor that practices about an hour north of Brisbane, Australia. And he is also the author to his book, Snored to Death. So today we're going to be talking about sleep disorder breathing and in children and teens, and mainly how it relates to bedwetting. So my interest in this topic really stems from my own personal story. I had a bedwetting issue all the way up into my late teens, and it caused a lot of psychological and social impact for me. And it wasn't until recently that I really connected the dots between my mouth breathing, my upper airway resistance, and the connection to bedwetting and other health issues. So recently I conducted a survey, a parent survey of parents that have children who wet the bed. And one of the questions I asked was if they had ever heard of the connection of sleep disorder breathing. 34% had never heard of it, and 53% have heard of it, but didn't really know much about it. So I also asked if they were satisfied or dissatisfied with the health care that they have in terms of addressing the issue with their children. And 34% are very dissatisfied, and 45% claim they were dissatisfied. So my goal here is to bring awareness on the connections of sleep disorder breathing and bedwetting, as well as offer parents some help in comprehensively addressing the issue with their kids. So with no further ado, we'll turn it over and start the chat with Dr. McIntosh. Thanks for joining me today.
Thank you for having me.
Yeah, so I guess maybe first let's just define what sleep disorder breathing is. A lot of people know what sleep apnea is, and that's part of it, but it's more than that.
Yeah, absolutely. So, I mean, sleep apnea is a good place to start the conversation because it then sort of moves forwards from there. So, we have a condition or a situation, and it applies to children and adults, but as you've said, we'll just stick to children for the time being, where there is some form of physical obstruction to the breathing to the point that when someone takes a breath in, they're actually not able to get that breath in as they should. So we can measure that. We can see that they're trying to breathe, not getting a breath in. So we call that apnea, and the derivation of that is from Greek. So nea means breath, and the a means without. So it means without breath.
Okay, interesting.
So that's the meaning of the word apnea. So, and then we have, as you said, obstructive sleep apnea is some form of physical obstruction. It's the equivalent of someone being choked, but instead of it being choked from the outside, they're being choked from the inside.
Oh.
So they're basically choking themselves. That's actually what's going on. And when we've looked at children, we realized that there was a group of children that had this obstructive sleep apnea. We realized that they weren't sleeping very well, or they were waking up tired. They're having trouble during the day, affecting their school, their behavior, their emotions. And we started addressing that from an ear, nose and throat point of view, focusing mostly as surgeons at looking at things like tonsils and adenoids.
Right.
And we noticed a huge improvement with the children. But then we had this observation that we had children that they weren't stopping to breathe, but they were struggling to breathe. They were sort of just overcoming their obstruction, but they were still having a lot of the daytime problems, much as the obstructive sleep apnea children were. And that was in due course defined as what we call upper airways resistance syndrome. So not full obstruction, but enough to cause symptoms and disrupted sleep as part of it all. Then we started to notice that even children that were snoring on a regular basis, and we sort of define that broadly speaking as probably at least 4 nights of the week or more. And I think it's important to qualify that we don't grade the snoring. It's either a yes or a no. Often I'll ask parents, "Oh, do they snore?" And they go, "Oh, not that much."
Right.
The answer that is a yes.
Yeah, or maybe you can't. It's barely audible, but it's still
exactly.
a snore.
It's still a snore, and the same applies to heavy breathing. And we noticed that those children, likewise, there was a group where they were having that, and it again was affecting them during the day. and then we bounce down to mouth breathing. So they don't even need to be noisy. If the nose or breathing through the nose is somehow obstructed, and to deal with that, they are breathing through their mouth, so they're basically bypassing the obstruction. They may not have noisy breathing, but the problem is that even mouth breathing is not a normal breathing pattern, and it does have impacts on the physiology. And without going into the fine print, the net outcome of that is that mouth breathers have a lower oxygen blood concentration level to the point that it actually can affect, again, sleep quality and then subsequent behavior, education, and so forth during the day. So that whole spectrum of presentations is encompassed by the term sleep disordered breathing. So it means some form of breathing issue that has an impact on sleep quality, that then has an impact on daytime function issues.
Gotcha. Wow, that was really an excellent explanation. Thank you. So a lot of parents and even healthcare professionals claim that, when children wet the bed, it's because they're really deep sleepers. Are they really deep sleepers, or is there some other? Can you simply describe what is actually the pathophysiology of what's happening? Are they sleeping too deep, or are they actually on a high alert and therefore not registering the fact that they need to get up and go to the bathroom?
Yeah. So in the context of sleep disordered breathing, there's actually probably 4 or 5 things that go on collectively that actually lead to this issue. And I'll walk you through it slowly just to sort of try and separate them all.
Right.
So the first thing, for example, if you're a mouth breather, then your mouth and your throat tend to get dry, and that's a signal to your brain to drink more. So you have a fluid intake issue, which means that you'll have a larger urinary volume as a consequence, because
Oh,
that fluid's got to go somewhere, and that's where it ends up.
yeah.
So that's one element. The second element is that when someone has sleep disordered breathing, that's a body stress response, and what that generates at the sort of the brain neurological level is a panic response, the flight and fight response, which involves activation of part of the nervous system called the sympathetic nervous system. And that involves the release of what over here we call adrenaline, and over there you guys call epinephrine, I think. But we'll pass by that, and most people are familiar with adrenaline, so we'll stick to that one because
Right.
that's what I'm
Okay.
going to be more familiar with.
Yeah.
So, but they get an adrenaline surge, and that adrenaline surge has several implications. One of the implications is that it makes the blood pressure go up.
Mm-hmm.
The other implication is that it increases the muscular tone of the wall of the bladder, and other muscles as well.
Right.
Those that have sort of ever got sort of a fright or anxious, that you tense up. Well, that sympathetic nervous system activation and the adrenaline surge that goes with it, that increases the tone of the bladder. So anyone that, for example, has gone and done some sort of exam, like maybe for university or college, and you've basically just before you're about to walk in the door and sit the exam, you've got that little bit of adrenaline, that little bit of sweaty palms, and you've got
Right.
that absolute desire that you need to go to the toilet.
Exactly. Yeah.
Yeah.
I
All
can
right.
relate.
Yeah.
Yeah.
It's the same thing. Okay.
Right.
It's the same physiology. So we've got that contributing to it. Now, one of the things that happens with the blood pressure going up is that puts more pressure on the heart itself. And within the heart, there is a natural mechanism to try and keep the blood pressure equal. And it's generated through a hormone. Now, the heart's divided into chambers. We have a left and a right side of the heart, and then there's 2 chambers per side. So the heart has 4 chambers. The smaller chamber is called the atrium. So if you ever walk into a hallway or an entertainment center, the reception area, they may call it the atrium. Well, that's the same in the heart. The smaller receptive area is called the
Okay.
atrium.
Uh-huh.
Okay. and within the wall of the atrium, there are pressure receptors. And if they notice that the pressure is going up, it will then result in the release of a hormone called atrial, which fits in the atrium, natriuretic peptide. Now, natriuretic is actually derivative of, again, it helps to sort of know how words are formed. Sodium is salt, okay? So table salt is sodium chloride. The chemical abbreviation for sodium is Na. Na is also basically the derivative of relationship to how we get that natriuretic, because natriuretic relates to sodium.
Got it.
And it's a hormone, so hormones can be either a steroid or peptide, so it's a peptide. So it's called atrial natriuretic peptide, which I know is a mouthful, so we'll just call it ANP, just to sort of summarize. But what happens in short is that what it does, it releases that hormone, which has an effect on the kidney to excrete more sodium. Now, when you excrete more sodium, you also have to take fluid with it.
Yes.
So it's a body response to take the pressure down by reducing the circulating blood volume, by allowing the kidney to filter more salt and hence water out of the system. So as a result of that, we have the bladder filling up more.
It's an increase of urine.
It's an increase of urine.
Yeah, okay. That makes sense.
There's also another factor in play, is that another way that the body copes with this is, in terms of regulating fluid, is there's what's called, basically diuretic hormone, okay? But it's called antidiuretic hormone. And what happens is that switches off, which means that you actually then make more urine, because the antidiuretic hormone is a conservation of water. So if you turn that off, then the corollary of that is that you start to lose water. So you actually have two hormonal changes in terms of atrial natriuretic peptide, ANP, and antidiuretic hormone, ADH, which collectively result in a larger urine volume. So we have a larger urine volume, we have a bladder that is more stimulated to empty, and then we have a child that is not sleeping properly, they're not getting good sleep quality, they are tired during the day and exhausted through the night. And like you said, it gets summarized as, oh, they're just super tired and they just sleep through it. Well, that's only one element of it. You've got all those other factors in play. The increased fluid intake, the increased bladder tone, the increased blood pressure, the hormonal changes, which collectively end up with the perfect storm for bedwetting.
Yeah, sounds like it's a cascade effect of, from one end to the other.
It's basically anything and everything that could go wrong, all go wrong at the same time.
Wow, it's complex. Really is.
And and I think that's if you go, it's nice to make things simple, but it has to be obviously thorough enough that you understand the whole story.
Exactly right. Yeah. No, that you did a great job explaining it. Yeah, thank you. Right.
Good.
So in terms of, well, we already kind of touched on this. I mean, bedwetting is just one side effect that can happen with sleep disorder breathing. I mean, there's a lot of other health impacts on the child, like you mentioned, in terms of, being tired during the day and the ability to focus and to learn. Are there other things that go along with that?
Yeah, I mean, when you scratch under the surface and you start reading on the topic, and you break it down into different body systems. So you think, all right, let's talk about one part of the body. So start at the top of the head. Let's talk about the brain, because everything that is manifest in terms of concentration, behavior, emotions, education, that's all related to brain function. And we've done the research and the science where we look at brain function in these children. And what we can see is that there are derangements. So anyone that's had the experience of having their own children and knowing that, what sleepless nights as a parent can have in the first, months and years of having a child, and how, People talk about pregnancy brain, and then you have the child and you're still not getting great sleep, and you're just in that zombie type state. Well, this is children that can't breathe properly all the time. That's them.
Yeah.
So we know that if you're tired, you're going to be grumpy and miserable and emotional. That's children. They're prone to getting angry. They're prone to getting upset.
Right.
We know that your ability to concentrate is affected, hence the education goes. People notice that their behavior becomes erratic because they've got the emotional elements and the concentration issues conspiring against them. So, that's just the brain. And when we actually go and do brain scans, we can actually see changes in the brain. We can see parts of the brain are not functioning properly, and we can even see parts of the brain are dying off. And this is in children.
Oh, that's
So, so,
scary. Boy.
so this is a reality that I think, we really need to turn around the understanding and perspective of sleep and its pathologies, because we spend a third of our lives asleep. When people talk about health and well-being, they talk about, well, it's your diet and your exercise. A lot of it's your sleep,
Yeah.
and that's the one thing that, we need to really pay more attention to.
Right.
So the brain's one body system. Another body system that I've already alluded to is the cardiovascular system. So that's the heart and the blood vessels. And as I said, these children, it's adults too, but these children are getting high blood pressure. That's not a good thing.
No.
And what we've speculated for a while, and we're more convinced than ever, is that having this sleep disorder breathing in childhood changes the way that the heart and the blood vessels react in the future, such that many of these people are probably ending up on blood pressure medication as adults as a consequence of not being able to breathe properly as a child.
Right. Yeah. Not to
So,
mention the increased risk of Alzheimer and
yeah, absolutely, all those things. Yeah.
diabetes, and it all
Well,
kind
that's
of.
the other thing I was going to say. We've talked about some of the body hormones. The perfect body hormone to talk about is, as you're alluding to, relates to diabetes.
Yeah.
The alterations in the body hormones, the alterations in the sympathetic nervous system with the adrenaline changes, they're all precursors to developing blood sugar regulation issues and hence diabetes.
Right.
So there's absolutely nothing redeeming about not being able to breathe properly, and I find it extraordinary that the one of the basic premises of survival is being able to breathe, and that any sign of a breathing problem really needs to be taken seriously. But there's an element of complacency, and there's also an element of ignorance as to how important it is to breathe properly, not just during the day but also during the night. People that are sporting people will, their sports coaches will be, training them how to breathe properly. You go and do yoga or Pilates, they teach you how to breathe properly. You go to a relaxation type session, they talk about breathing. There's a very good reason that people are talking about breathing. It's not just for the survival as we're sitting here, but it's also for your health to be able to do it properly.
Right. Yeah. And something really struck me. I can't remember exactly which book it was I was reading, but it might have been The Dental Diet by Dr. Stephen Lin. But in there, he says something about, oxygen is the number one nutrient. And I mean, well, duh, but I'd never really thought of it that way. When I think about nutrients, I think about the food I eat, and I eat a really healthy diet. But it's it it's getting exercise, and it's eating the right things, and that's really focused on. But sleep seems to be kind of down the list for people, and
Yeah,
breathing.
which
So
is unfortunate, because
yeah,
if you don't sleep properly, you won't have the energy during the day to exercise.
exactly.
If you don't sleep properly, your food seeking behavior changes
Hmm.
to a situation where you will seek out high calorie but poor nutrition foods, which then leads to overweight and so forth. So the underlying thing for a lot of people that have issues with getting motivated to exercise, issues with food, and what we call food seeking behaviors, is that they're not sleeping properly. And unless the sleep is addressed, those things don't get better.
Yeah, it makes total sense. It really does. Wow. In terms of sleep studies for kids, again, it seems to me my early impression is that, you know, doctors are starting to screen for this, but they're just maybe looking for apneas and they're not paying close enough attention to the mouth breathing and the upper airway resistance. Do you see that
Yeah,
trend
so
changing where they're looking at more comprehensive sleep disorder breathing in children and
yeah,
adults?
so when we've looked at the science and looked at the research with regards to finding these children, a sleep study will give us a really good guide as to whether a child has obstructive sleep apnea or not. But then, so too, to be honest, will a parent taking a video of their child sleeping and making note of the fact that they stop breathing at night.
Okay.
So, but the problem with the sleep study is that it's looking at sleep apnea versus not, whereas we actually need to look at sleep disordered breathing versus not. So the important thing that we've realized is a normal sleep study does not mean normal breathing.
Right. Okay.
Because if you have upper airways resistance syndrome, it means that you're not stopping breathing at night. So we won't
It's
pick
not going
up
to
that.
pick it up.
No,
Okay.
if they're snoring, they can measure the snoring and note that it's there, but then they will say, but there were no apneas. But that's not the point. There was snoring, and then you have the issue of, well, if they're mouth breathing, then that in its own right is an issue because they're actually breathing to bypass the obstruction that they've got. So when we looked at the sleep studies, basically, we sort of said, look, this is what we can measure, and this is what we're noticing. There's not a very good relationship between the sleep study result and which child will have a problem, and also which child will benefit from surgery or other treatments. So it's a problem with regards to the test, that it doesn't really tell us the spectrum of problems that we're actually wanting to know about in the first
Yeah.
place.
Okay. Now, in terms of treatment for sleep disorder breathing, you know, tonsils and enlarged tonsils and adenoids is probably a big one. What else?
Yeah.
I mean, if
So
somebody has large tonsils and adenoids and they have them removed, but yet they are still wetting the bed, is there something else these parents, is there a further road to go down with the sleep disorder breathing, or does it
yeah,
end with
yeah,
the tonsils and adenoids?
yeah. So tonsils and adenoids traditionally is the thing that's been focused on because it's the thing that is by far the most dominant factor. And it's also the one where having that done has the best outcomes in terms of an immediate response. So I think the important thing is that if a child has sleep disorder breathing, while the focus may be on bedwetting for some parents, the science shows that around about 40, so that's 40, so 40% of the children that are bedwetting with sleep disorder breathing will stop bedwetting. So it's not 100% outcome. But 40% is a good place for those where they fall into that 40%. You take
Mm-hmm.
what's there.
Right.
But the important thing is outside of the bedwetting is that there are significant health benefits regardless of the bedwetting.
Exactly.
Their brain is better, their cardiovascular system is better. So one should not be disappointed if the bedwetting persists because there's all those other benefits that were thrown into the mix.
Mm-hmm.
However, in sleep disordered breathing in a more broader sense, not just focusing again on the bedwetting, it's a combination of factors. So it's a combination of how big is the airway and then what is inside the airway that's causing a blockage. So for example, we can have a situation where the jaws of a child may not be growing properly. Their upper jaw may not be growing outwards and forwards properly. Their lower jaw may be sitting back. That combination of effect reduces the space within the airway that would be otherwise available. Simply because if you look at my head and you squash it in, there's less
Yeah.
room. It's
Everything.
just simple math.
Mm-hmm.
So sometimes we need to involve the dentists, and the dentists need to look at developing the jaws, taking the jaws wider, bringing the jaw forwards, which not only is good from a airway breathing point of view, but obviously makes more room for the teeth, can change the facial characteristics into, you know, a different sort of presentation that, you know, some people argue is more aesthetically pleasing. So that's, you know, essentially from the dental point of view. But the other thing we've realized is that with these children is that they can have hay fever and allergy problems. So you might need to deal with the hay fever and allergy. It may not be a tonsil and adenoid problem. If the nasal passages are blocked because of allergy swelling, well, there's still going to be a mouth breather as a result of that being present. The middle part of the nose called the septum may be crooked, so they may have a deviated septum that needs addressing. And then the other thing that ties in with all this is muscle tone. So we've learned that the muscle tone and function around the throat in children that are not breathing and sleeping properly can be diminished and decreased. And what that means is that when we breathe in, the muscles, instead of holding the throat open, can actually collapse to some degree, and that can limit the airway as well. So we can have a range of people that need to be involved, from an ENT, who's probably the first place to start, because they are the ones who can make an assessment. You know, do they have allergy problems? Do they have tonsil problems? Do they have adenoid problems? I think the ENTs dealing with this should have some basis of knowing about things, you know, like tongue ties, muscle tone, jaw development, so they can sort of go, okay, well, there's no, you know, ear, nose, and throat problem, but these jaws are not developing properly, so we need to get our dental team involved. The muscle tone's low. We need to get some functional rehabilitation of the muscle tone, and, you know, for example, or they may go, yeah, look, this is an allergy problem. We need to get some allergy treatments going.
Yeah.
And I think that's where the ENT, you know, is really the best place to start.
Okay.
Simply because most of the time they'll have something they can do to help, but also they can actually categorize the other problems,
Yeah.
because they're the only one that can actually look at everything that we're talking about. You know, dentists can look at jaws much better than anybody else. There's therapists that can look at muscle tone much better than anybody else. You know, allergy doctors deal with allergies better than anybody else. But the ENTs can look for all of those things, and I think
Yeah.
that's why an ENT assessment is so crucial as a starting point.
Okay.
But they're not the be all and end all in terms of what's involved in managing it all.
Yeah. Now, do most ENTs like yourself have that broad perspective of looking at airway, or I mean, is it, I guess what I'm asking is, it, how easy is it to find someone like yourself that has this interest in airway?
Sure. So I think that, you know, the important thing for people to realize that ENT is a very big specialty. And this is where people get tripped up a little bit, is because there are different types of ENT doctors, just like there are different types of orthopedic doctors.
Right. Okay.
So, you know, orthopedic surgeon might specialize in sports injury, or might specialize in spinal, or might specialize in hip replacement, or ankles, or shoulders. So no one has a problem understanding that concept. They sort of go, oh, it's an orthopedic surgeon, but there's no point seeing the orthopedic surgeon with a shoulder injury if they're a hip specialist.
Yeah.
You know, there's no point. But people don't have an issue with that. They have a natural understanding that that's just automatically the case. Unfortunately, when it comes to ENT, people haven't cottoned on, you know, in a general sense, that it's a huge specialty, and that people do differentiate into things. So some people will differentiate into, for example, doing throat cancer work. Others might differentiate into doing pediatrics. Some might do nose and sinus. Others may do major ear problems. Others may do facial, you know, cosmetic surgery type things like rhinoplasty and that sort of thing.
Yeah. Okay.
So people need to understand that it's not about seeing the ENT, because that doesn't make sense. What you need to do, as you've alluded to, is you need to see the ENT that's relevant for the condition. So if we were talking about, you know, some sort of ear disease, we're saying, well, you need to go and see the ear specialist, and no one would think twice about that. So when it comes to this, you know, the first thing is, if you're talking about adults or children, because you need to go, all right, well, is this you know, am I dealing with an adult or a child here that needs assessment? Because that may make a difference.
Sure.
And then the other thing is that, okay, is this something that, you know, is more related to airway type problems? And in which case, you know, I need to find the you know, as you said, the airway one. And it is a matter of asking around, because it's not a huge area of interest or focus for a lot of ENTs. They certainly, do a lot of the surgical procedures and so forth that we, might be talking about,
Mm-hmm.
but they may not be completely up to speed with, what all the science and research shows in this area. So, for example, there's still a persisting, belief even amongst ENTs that it's all about having tonsillitis. If a child hasn't had tonsillitis, we don't need to take them out. But if you have large obstructing tonsils, the last thing
Yeah.
that child needs on top of that is tonsillitis.
Yeah.
And pediatric ENT perspective, in my clinic, 80 to 90%. So that's 80 to 90, 80 to 90% of tonsils that I'm taking out, the child does not have a history of tonsillitis. They simply cannot breathe properly.
Yeah. They're just so big that they're blocking the airway. Yeah.
Yeah, exactly.
Oh.
It's a plumbing problem.
Mhm.
It's not an infection problem. It's a plumbing problem.
Yeah. Makes sense.
So it is important to try and ask around and just get some clarity as to you know what people's training and experience is, and
Yeah.
are they sort of up to speed with this. And it is not a criticism if they're not, because I'm not up to speed with head and neck cancer things, because I don't
Yeah.
do that part of ENT anymore.
Yeah. You
But
can't
I
be.
know, no, you can't be everything to everybody, but I know who
No.
does it, and I will send people in their
Right.
direction,
Yeah.
so that they can then take over.
Yeah.
So the problem with the airway though is that people get an answer from somebody, and then that's the end of it. They sort of go, oh, okay, there's nothing to worry about, and it's not necessarily the case.
Right. Yeah. Well, and I've noticed that some parents are, their kids have had their tonsils and adenoids out, but then that's kind of where it stops. Um, they might still be mouth breathing,
Mm,
even though they've had their tonsils and adenoids out. There might
yeah.
be some other issue, maybe a tongue tie or.
Mm. Well,
Um,
the most common scenarios in that situation, the first thing is that once the tonsils and adenoids come out, you've got to wait 3 months. You have to wait 3 months. There's a whole lot of physiology that needs to reset.
sure.
It's
Yeah.
not like flicking a light switch and you've unblocked it and it all drains properly.
Yeah.
So that's the first thing. The second thing is that there are ways of taking out the adenoids that are more effective than others.
Oh.
So certain techniques actually result in the adenoids not being removed adequately.
Mm.
So it's important to sort of know, what's involved in terms of, how it's done procedurally, in terms of how the operation is done. And then the other thing, as I said, is that if they've got a nasal problem, if they've got nasal allergies as well, the adenoids, just for the benefit of people listening, so the adenoids sit behind the nose. So you have the nasal passages, okay, running back and forth, okay, and then behind the nose there's a space, and in that space is where the adenoids are. So when you take the adenoids out, you're unblocking the space behind the nose. But if the nasal passages themselves are blocked for some reason, they're still going to mouth breathe. So unless
Yeah.
the nose has been assessed and examined, often using a nasal telescope of some sort to get a good look within the nasal passages all the way through them, you could take the adenoids out, but the nose is still going to be blocked.
Yeah.
As I say to parents, if you have a car and it's got a flat tire at the front and a flat tire at the back, and I fix the one at the back, well, we can say we've made things better, but most people would recognize the fact we've still got a problem.
Right. Yeah. That's a good
So,
point.
so you need to deal with the whole picture, not just part of it.
Right. And then mouth breathing can somewhat be habitual, can't it? I mean, if
Well,
you've
we've got to be
always
careful.
been a mouth
We've
breather.
Yeah, we've got to be careful with the English language. English language is a beautiful thing. So habitual in terms of the strict definition of the word means doing it on a regular basis. That's all habitual means. Habit means that you're doing it for no good reason. And this is where we get a bit pedantic with the wording, and this is sort of
Mm-hmm.
one of the quests of mine. Habitual mouth breathing means that you're doing it on a regular basis. You cannot call it a habit in that you're doing it for no reason if there is some form of pathology. So 80 to 90% of the time with habitual mouth breathing, it's because there is pathology. It's either allergies or adenoids or tonsils or deviated septum or problems with the jaw growth and development. So 80 to 90% of the time, it is not a habit, even though it's habitual.
Okay.
So, all right. I know it's a
Yeah.
beautiful thing, isn't it? No wonder people struggle with English. All right. But, it's important to make sure you get this terminology right, because
Oh, right. Yeah.
one person can use the word in one context that they think that you understand that you're using it in, but you may be miscommunicating with each other in the process without realizing that you've done so. So, to make it simple, any child, any person that is mouth breathing, that is a sign of an ear, nose, and throat problem until proven otherwise. Because in the vast majority of them, there will be some form of obstructive pathology. Now, once that pathology is addressed by whatever means, medication, surgery, whatever's appropriate, dentistry, whatever's appropriate, there's still a lag period before the brain will reset everything. And then generally speaking, I find that takes around about 3 months.
Okay.
If the airway is clear, the function is there, but the use of it has not been restored, so they haven't resorted to nasal breathing, that's when I look at rehabilitation and functional therapies to then address that, but not before. There's no point trying to force somebody to breathe through their nose if it's blocked, just like there's no point trying to force somebody to walk on a broken leg.
Yeah. You need the structure to be proper before the function can follow.
Exactly.
Yeah.
Exactly.
Okay. Yeah. Makes sense, really. Well, I won't keep you much longer. I just have like one more question, and then we can wrap it up. If there's anything else you want to add beyond that, that's great. In terms of your personal experience in your practice, do you actually track outcomes for bedwetting
Yeah, so
specifically?
so I reflect on your story, because the one that sits with me, to this day, and this will be over 10 years ago now. It's probably closer to 12 years ago. Was a teenage boy, 14 from memory, who was struggling at school, but more so was having the issue where he couldn't do sleepovers. He couldn't go and stay at his, as we say over here, his mate's house,
Yeah.
because he was wetting the bed. And I saw him. He had huge tonsils, huge adenoids, and major allergies going on. We addressed that surgically and medication. He stopped wetting the bed. He was a new child. It was
Yeah.
like the years of angst had basically been lifted off of him,
Yeah.
and he could do everything that every child otherwise would do without any
Hmm.
concern, which is to just get out there and
Yeah.
enjoy life and be free. So that sort of story really resonates, just on the impact that it has, because it had been left to that point, of age, where it could have been addressed.
Hmm.
Every parent's happy, sort of, their child stops wetting their bed when they're 4, 5, 6, or 7 years old. So if we happen to do this sort of surgery and that it gets there, it's sort of like oh, okay, good, we're there. But when it's dragged on for that long, then it has that much of an impact on someone. They're the ones that you remember more than anything else.
Yeah. Yeah. Right.
As you're going through doing what you're doing, and you just sort of go, you know what, this 4 or 5 year old will never know what I just saved them from.
Right. Yeah.
They've literally had their lives changed, and so forth. I don't pretend that I'm saving lives, but in terms of curing cancer and those sorts of things, but it's certainly
Yeah.
changing lives
Oh,
substantially, to
for
the point that
sure.
it's giving people a different life to the trajectory that they would otherwise have had.
Yeah. Earlier is always better.
Yeah, it is.
Yeah. Well, and for that 14-year-old, I mean, the immediate reward was, obvious that he could socialize and, not have this
Yep.
angst. But in terms of going forward with, other health issues in his life, you know,
Yep.
yeah.
Yeah.
So,
Yeah.
yeah, I mean, the bedwetting seems to be, it's on the front burner. It's causes a lot of stress in families, but
Of
it's way
course.
bigger than that. Like you
It,
said,
it's
it's
it,
going
it is
forward.
way bigger, but
Yeah, it's way
it's the
bigger.
thing that's more obvious, and it's the thing that like you said, a lot of parents don't put two and two together on and so forth. But it's a benefit there to be had. But the other thing is they don't put two and two together for the brain things and the cardiovascular things,
Right.
partly because they just don't know.
Exactly. Yeah.
They just, you don't know, you can't know what you don't know. And that's, I think,
Right.
the advantage of these sorts of opportunities. We can come together, you and me, share some knowledge, spread that knowledge. And the important thing is that it's one thing to have the knowledge, but the other thing is you've got to do something about it. So there's no good knowing these things and then not acting on it. So I'd certainly just encourage people to get motivated, overcome their anxieties that they may have, any of the fears they may have. If your child cannot breathe properly, that's a serious problem, and any treatment that's presented should come as a form of relief, of a thank goodness moment, rather
Right.
than a oh my goodness moment, because the oh my goodness should be about the breathing problem. That's the
Yeah.
thing that people should be worried about.
Right. Yeah. Well, the other thing I'll add before we say goodbye is just, in terms of the role of the orofacial myofunctional therapist and their ability to act as gatekeeper in a way in assessing a child with their um, breathing issues in terms of referring, they generally have a network of ENTs, dentists that they know that specialize in airway, and they can refer those kids, out to these specialists to get these issues addressed, and and if need be, also help them restore function in terms of,
Absolutely, yeah.
keeping those lips sealed and that tongue up,
Yeah,
and yeah,
yeah.
so
Absolutely crucial element of the whole process from beginning to end, as a, not just from a screening point of view, but also from a rehab point of view.
yeah.
Absolutely.
All right. Well, hey, this has been great. I really appreciate your time, Dr. McIntosh.
It's been a pleasure.
Yeah. All right. Well, take
Right.
care.
Thank you. You too.
Bye.